My topic is on dyslipidemia therapeutic update. We need to remember about the burden of cardiovascular disease, what we are facing. Globally, it is about 31% of all deaths occurring is only due to cardiovascular disease. It is also the leading cause of premature death between the ages of 30 and 70 years. It is clearly seen in the data that about 54.5 million people suffer from cardiovascular disease in our country. Approximately 25% of the deaths occur only due to atherosclerotic cardiovascular disease. With respect to prevalence of hypercholesterolemia, it is estimated that about 10 to 15% of rural population and 25 to 30% of urban population suffer from hypercholesterolemia. In the first phase of ICMR INDIAP study, 13.9% of the study population had hypercholesterolemia and higher levels of LDL cholesterol ranging 11.8%. We need to remember this important message, which is derived from various data available in our country. 40% of Indians with coronary artery disease are less than 40 years of age. 25% of those dying due to coronary artery disease are less than 40 years of age. In Indians, coronary artery disease develops 1 decade earlier than other ethnic groups, more severe coronary artery disease, and high mortality. As has been rightly pointed out by Dr. Venkateswaran, South Asians are at a higher risk group, as has been dictated by American College of Cardiology. We try to recollect what is available in the literature. Way back 1933 in Arteriosclerosis Journal that was mentioned about atherosclerosis. In the absence of hypercholesterolemia, that is raised LDL cholesterol or remnant particles, it is virtually impossible to cause atherosclerosis in an experimental animal. All of us know about this elegant study done by Salim Yusuf and his group, Interheart study, which had evaluated 9 commonly occurring reversible cardiovascular risk factors, out of which dyslipidemia or ApoB-A1 ratio became the #1 risk factor for pushing patients for an acute myocardial infarction. It is also true in another study, Dr. Mohan was also part of the study, PURE study, where they had evaluated the risk factors. Hypertension was the most important risk factor. Next, almost equal to that, is a lipid, particularly in South Asians, when compared to the global data. There are 3 test tubes with this. Only the plasma, which is depicted here. On to the left side, you can just see it is yellowish in color, which contains more of LDL, more probably of LPA, responsible for increased cardiovascular events. When you have hypertriglyceridemia with an increased levels of remnant particles, triglyceride-rich lipoprotein particles, you have more incidence of cardiovascular disease. That is the emerging data. When you have abnormally elevated triglyceride, more than 2,000, 3,000, then they have problems of chylomicronemia. Actually, the plasma or the serum is turbid, which is responsible for increasing pancreatitis and less of cardiovascular disease. If you look at this data, you will understand that the LDL cholesterol, which is maintained throughout the life of an individual, probably plays a role for him to get pushed for an early myocardial infarction. If you have people with 80 milligrams of LDL cholesterol, his chances of getting myocardial infarction at the age of 100 years. Whereas if somebody has LDL cholesterol 125, which is maintained throughout his life, it is likely that the lifespan gets reduced to 64 years when he may get myocardial infarction. Suppose somebody has 200 milligrams and above, it is clearly seen that the risk of getting myocardial infarction, as far as the age is concerned, comes down to less than 40 years of age. Excellent information, what we have derived from cardiac study. So, ladies and gentlemen, LDL plays a central role. LDL plays a pivotal role in atherosclerosis. It is our duty to reduce it as early as possible. Clearly seen by various studies, molecular studies, biological information, epidemiological data, observational data. But the best evidence comes from the familial hypercholesterolemia. No other risk factor responsible for pushing patients for atherosclerotic cardiovascular disease other than the cholesterol LDL. It is also seen that randomized controlled trials which had used statins, HMG coenzyme reductase inhibitors, the more the reduction that was witnessed in primary prevention trials and secondary prevention trials, the more benefit that is seen, not only in morbidity, but also in mortality. Stressing the importance that we need to control the LDL cholesterol all the time to get the maximum benefit that is witnessed not only in primary and secondary prevention trials. people who have received statin, you look at the information. People who received the statin, and if their levels of LDL cholesterol is around 50 milligrams or so, you can just see it's only 4.4% of secondary events. Whereas when somebody is keeping the levels above 100, it is 16%. So the event rates comes down when you lower the LDL cholesterol. So lower the LDL cholesterol is better. That concept started emerging only from heart protection study, which at first time evaluated the efficacy and safety of statin, not only in primary prevention approach, but also in secondary prevention approach. If you reduce the LDL cholesterol by 50 milligrams, you get a benefit of nearly reduction of 50%. But unfortunately, people who receive statins, many of them do not have probably a capacity to reduce the LDL cholesterol. Nearly 40% of them still keep it at a higher level. These are the meta-analysis data, which clearly indicates that there is a reduction of 22% in the major vascular events, 10% reduction in all-cause mortality in the first one. The second meta-analysis, which had evaluated various therapies, again says 23% reduction. The last one, statin, ezetimibe, PCSK9, 19% relative risk reduction. If you look at all this data which are projected here from primary prevention, secondary prevention trials, it is clearly seen that there's a residual risk. In spite of receiving high dose, moderate dose, tolerable dose of statin, you still get a risk of getting cardiovascular events. What is the range of risk? 55 to 70% of the people are still at a high risk of developing a problem. How to reduce the LDL further? You cannot go on escalating the dose of statin because it may be probably not good to have the same approach for every patient. It all depends on the intensity of the statin what you're using. All that you should do is to select some other drug called ezetimibe, which is available in our country. The study which had focused attention of the safety and the efficacy of using a non-statin drug to that of the statin is the IMPROVE trial, which had evaluated people who have a stable coronary artery disease following myocardial infarction. It is clearly seen that 53 milligram was the LDL cholesterol that was reached by adding only 10 milligram of ezetimibe with that of simvastatin 40 milligram. So the indication of ezetimibe, not only in non-diabetic, but people with the diabetes, has shown the maximum benefit. Nearly 14% risk reduction in those people with the diabetes when compared to people without diabetes, just by adding only ezetimibe to the high dose statin. It is also seen people with the diabetes with the polyvascular disease, they get the maximum benefit. The number needed to treat is only 11 when compared to people with only diabetes or people with the polyvascular disease, no diabetes. So compared to all these groups, diabetic persons who have polyvascular disease will get the maximum benefit when they get an additional drug, ezetimibe, over and above high dose statin. That's the message that you derive from this particular study. It is also true that if you are using a statin plus an ezetimibe, it is possible to get the percentage reduction in atheroma volume by the intravascular sound studies. Let me now try to take you to the PCSK9 inhibitor, which is now available in our country. The good old study is ODC long-term study, and the other one is the Osler 1 and 2 studies, clearly indicated if you are bringing down the LDL cholesterol by 50 milligrams, it is possible to get 50% reduction of LDL. You do get a reduction of 50% risk for these patients. So based on all these reports, based on all these studies, based on all meta-analysis, the Lipid Association of India came out with the recommendation that people who are at a very high risk need to keep the LDL levels less than 50 milligram and non-HDL cholesterol less than 80 milligram as per the projections made here. That is what was actually projected in the year 2016. The first organization to come out with this recommendation before European Society or ACCA was talking about the target or the threshold. 4-year trial was a trial which had used the evolocumab in those patients with high risk, nearly about 28,000 patients. One arm received evolocumab injectable. They had given 140 milligram once in 15 days or 420 milligram once a month. And they have followed up these patients for a period of 3.8 years compared to the placebo. Very, very clear to see people who were having 93 milligrams of LDL within a matter of 1 month, they were able to get down to the levels of 30 milligrams. And it was maintained even after 48 weeks of study, continued throughout the period of study, the same reduction of LDL cholesterol was observed, thereby indicating the more the reduction of LDL cholesterol. Does it show benefit? Yes, 15% reduction in the primary endpoint was observed when the levels of LDL cholesterol was brought down to 30 milligram. If you look at this data, not only 15%, which is for 30 milligrams, but you bring it down to the levels of 20, you get more benefit. Some people have reached even levels less than 10. Surprisingly, the cardiovascular risk is estimated to be around 31% risk reduction in this group of people. So, ladies and gentlemen, the message is very clear. Do you know how to reduce LDL? We know. How much you should know? Reduce it? We don't know. We are not in a position to say what is the exact lower level of LDL cholesterol beyond which you will not get benefit. That's the message, what I thought I should give it to you. So having seen this, what about the Glasgow study, which had evaluated the efficacy of PCSK9 inhibitor, evolocumab, by showing that there is an atherosclerotic cardiovascular burden, comes down by the reduction of the plasma volume, the atheroma volume. The next drug that was introduced as a PCSK9 inhibitor is alirocumab. This study was done in patients with acute coronary syndrome. Nearly 29% of the patients with diabetes, they received alirocumab subcutaneously, and compared with the placebo, they were able to bring down the LDL cholesterol to the levels less than 50, less than 30, less than 40, and less than 25, 15. These are the things which are depicted here. Those people who received this drug, when their levels were coming down to the 15, that was not the investigator's goal. So they pushed the patient to the higher level by reducing the dose. Like that, they were keeping the drugs for some time, and they followed up these patients, surprising the same amount of reduction of cardiovascular events, which were noticed in the 4-year trial, was also observed in the Odyssey trial. People who reach the levels less than 15 milligram, 1.5, there is an additional benefit, nearly about 29% risk reduction, not 15%. 15% was seen in the original study. In the analysis, subsequently it was revealed those patients who had levels less than 15 milligrams of LDL cholesterol, by using an alirocumab, it was clearly seen that the reduction was coming down to 29%. So the message is very clear, ladies and gentlemen. If you use a PCSK9 inhibitor, either alirocumab or evolocumab, only evolocumab is available in our country. It is an injectable form. Reduces LDL, VLDL, non-HDL, lipoprotein little a, remnant particles, LDL particle numbers. What more you want? Everything is almost coming down. The European Society of Cardiology and the European Atherosclerosis Society started coming out with a recommendation how much you should probably keep it for high risk, low risk, medium risk. The last one, what I thought I should tell you, is a very high risk individual. Aim for 50% reduction from the baseline. Keep the levels less than 55 in the year 2019. In 2016 itself, Lipid Association of India categorized this very high risk, started telling you that you should bring it down to less than 50 milligram. That's the most valid information what I thought I should share. In fact, in 2020, we came out with this algorithm. We have updated it. Low risk, medium risk, high risk, very high risk. How to do that? Please go through the website www.lipid.net in. You will get this algorithm. All that you require is to keep this algorithm on your table and try to identify the patient who is walking in, whether he belongs to this group or that group or the other group. How to keep these levels? For example, if the person is having a low risk, moderate risk, try to keep the levels less than 100. The person is having high risk, keep the levels less than 70. Very high risk, try to keep the levels less than 50. If it is more than 50, try to intervene and then give them. We have introduced extreme risk group now, A and B. A with an established coronary artery disease with a high risk group, or a person with a very high risk group in the sense established coronary artery disease, polyvascular disease, diabetes with 3 more risk factors, target organ damage, extreme risk group B, where we recommend less than 30 milligram will be the ideal target through which probably you can give the maximum benefit for our patients. So this is how we are all justified in recommending 30 milligram for our patients based on all these evidences. In fact, it was approved or recommended or emphasized as the most important information by the Journal of Clinical Lipidology, USA. This is one of my patients, homozygous familial hypercholesterolemia, with a tendon xanthoma, with all the skin changes. She had seen me at the age when she was only about 11 years or so. She lost her sister in spite of the fact that I had told the parent that at any time the child would die because the LDL levels baseline was 720 milligrams. So homozygous, the other girl, after receiving treatment for a period of 3 months, she died. One fine evening, she died with severe chest pain. On the spot, she died. The drug that is now available to treat homozygous familial hypercholesterolemia is one. High dose statin, yes, I have given 40 milligram. Ezetimibe, yes. Bile acid sequestrant, yes. And then I added PCSK9 inhibitor. You know the level of LDL cholesterol, what I reached in my patient? 191 now. I've added even bempedoic acid. So number of drugs are available. You need to give a combination so the patient should become all right. The drug that is now going to arrive soon, the drug that has been tried in homozygous familial hypercholesterolemia is evenacumab. This drug was tried apart from all this high dose statin, ezetimibe, plus your bempedoic acid, apheresis. These group of people have shown a maximum benefit, irrespective of the fact whether they had LDL receptors absent or present. In those group of patients, they had shown maximum benefit. So by using this drug, moderate intensity statin, you can anticipate 30% reduction. High intensity statin, 50% reduction. You give high intensity statin plus ezetimibe, you can expect 65% reduction in LDL. Only PCSK9 inhibitor for statin intolerant patients, 60%. PCSK9 inhibitor of moderate intensity statin, 75%. PCSK9 inhibitor, high dose statin plus ezetimibe, you can reach the maximum level of reduction of 85%. Look at the academic body's recommendation. Only ACC, AHA has not told you the target. It has recommended anybody who has more than 70 milligrams of LDL, try to keep it down. 50% reduction, aim for it. Is there a target? No. Whereas all other academic bodies, you can just see, all of them had recommended that you should chase the LDL cholesterol. The initial recommendation by ACC, AHA is that start high dose statin, fire and forget. Now, the revision is that they are keeping the levels above 70, try to treat. Bring it down as much as possible or 50% reduction. That's the recommendation, what is being made without giving 50, 55, 70 and all those things. Bempedoic acid is a new drug. I think it is also available in our country now. Even IPCA has produced this molecule. This molecule actually acts one step before the statin therapy. Actually, it is the ATP citrate lyase inhibitor. So a drug which was tried and recommended by FDA to be used in those patients in whom we are not able to get the LDL down of following myocardial infarction, or those patients in whom we have tried this drug, particularly familial hypercholesterolemia, or those people with a statin intolerance, you can always use it. Where is the evidence? Clear harmony one study, clear wisdom study with a hypercholesterolemia, maximally tolerated dose of statin. They have shown a benefit of reduction of nearly 16% of LDL levels. They have also used it in statin intolerant patient. C-reactive protein also comes down. Yet another drug is inclisiran, which has not arrived in Indian market. Very soon you will get it. The advantages of inclisiran over the other PCSK9 inhibitor, evolocumab, is that it can be given once in 6 months. One injection once in 6 months. That's all. You get almost the same benefit as you get with the PCSK9 inhibitor. Instead of giving it once in 15 days, you can always go for once in 6 months. The drug is probably will be arriving soon in the second part of 2023. This drug is a wonderful drug. Having used all these molecules, non-statin molecules with the high dose statin, are we going to get the side effects of these drugs, bad effects of these drugs? Surprisingly, almost compared to the placebo, no problem except for the injection site reaction. Number one, if you use bempedoic acid, you may get an elevation of uric acid. If you use bempedoic acid, you may get a tendon rupture. These need to be kept in mind. Other than that, using a non-statin drug with a statin will not do any harm for your patients. This is the most important study called REDUCE trial, where everybody will be interested to bring down the triglyceride levels. REDUCE trial used icosapent ethyl ester, 2 grams in the morning, 2 grams in the evening, given for patients with diabetes with the ACS when their levels of LDL cholesterol reached nearly 70. They kept these patients for a period of 3.8 years or so. Surprising to see 25% reduction in the primary endpoint, 26% reduction in the secondary endpoints, thereby showing icosapent ethyl ester given in conjunction with statin, you do get benefit in not only reducing the triglyceride, but you get a maximum benefit in the primary endpoint. because people in the lower levels of triglyceride also has shown benefit. This is a wonderful drug which I am also using it for my patients with hypertriglyceridemia. Last but not the least, LDL. Again, it is gaining much importance. This is the one that is to be evaluated in every patient. Please remember, at least once in his lifetime, please submit him for LPA estimation. You ask for isoform insensitive assay, which will give you the details of this molecule in the form of milligrams. The international recommendation is nanomoles and not milligrams. You cannot equate it with the nanomoles like you do pounds and kilograms. You cannot do that. People are now trying to come out with some sort of formula, but currently we are using only milligrams. LPA, the drug that is in the pipeline is pelacarsen, which is very good drug. It seems phase 2 studies have shown promising results. Recently, Stephen Neeson was talking to me over phone, and he also had shown a lot of interest in this field. When I was discussing in a panel discussion, I was talking about lipoprotein(a). He said, very good information that you had given about LPA. We are in the process of coming out with some results. He had used this SLN molecule, which has shown 85 to 90% reduction in lipoprotein(a). Do you have cardiovascular outcome data? No, we don't have it. This is Apollo study, where they used this molecule, Stephen Neeson and his group. So, ladies and gentlemen, in 2022, we are now entering into 2023. We have already entered. The drug that we have seen is a statin. The next one is estimide. The third one is a PCSK9 inhibitor. The fourth one is icosapent ethyl ester. The last one is a bempedoic acid. All the drugs are available now except the inclisiran, which will probably arrive in the second half of this year. So, ladies and gentlemen, my final message as far as the LDL cholesterol is concerned is lower the better, earlier the better, longer the better. Thank you very much, ladies and gentlemen, for patient listening.